Hi, my name is Caitlin Omer, and today I am going to be presenting a lecture on the genetic disorder Osteogenesis Imperfecta, also known as brittle bone disease. The date today is November 27th, 2016. So, just to start off with, what is osteogenesis imperfecta? The characterization of it are bones that break very easily. It occurs due to a mutation on the COL1A1 and the COL1A2 genes, which are responsible for type 1 collagen production. And there are also possibilities of mutations on the CR-TAP and the LEPRE1 genes. However, those mutations tend to be seen in the recessive forms, which we'll go over later in the presentation. Originally, this disease was discovered by Dr. Olaf Jacob Ekman, who's a Swedish surgeon. He discovered osteogenesis imperfecta while working with patients in the 18th century. So this was something that was seen a very long time ago, but we haven't had advanced research in it until recent times. The odds of inheriting osteogenesis imperfecta are about 1 in 10,000. You got a 1 in 10,000 chance to get this anywhere in the world. Any child born could get this disease. And as of 2015, the National Institutes of Health report 20 to 50,000 cases of osteogenesis imperfecta in the United States. So, osteogenesis imperfecta has 8 different types, all of which we're going to go over in this lecture. We'll start with type 1. So, type 1 is the mildest form. It's got minimal to no visible bone deformity. With this type of osteogenesis imperfecta, bones fracture very easily, of course. However, most fractures occur before puberty. Brittle teeth and hearing loss in the age range of 20 to 30 are also possible phenotypes. Other possible phenotypes are blue tint in the sclera of the eyes and triangular facial bone structure. Type 2 osteogenesis imperfecta is the most severe form of osteogenesis imperfecta, also making it the most lethal. The lethal nature of this type of OI is a result from the lungs being underdeveloped due to the small stature from birth of the child. Collagen formation presents itself as abnormal, and there is severe bone deformity associated with several fractures. Death shortly after birth, if not in utero, is prevalent with this type 2. So bone fractures can also be seen in utero via ultrasound or after birth via x-ray. Most of the time, these fractures heal improperly, which can also be seen in scans done after birth. So type 3, osteogenesis imperfecta. Again, short physical stature. There's a barrel-shaped rib cage, which leads to respiratory problems, increasing in severity with development. Again, improper collagen formation, brittle teeth, hearing loss, spinal curvature, which can be seen in the picture to the left, tinted sclera of the eyes, and poor muscle and joint development. So, type 4 osteogenesis imperfecta. The severity with this type lies between types 1 and 3. Most bone fractures will occur before puberty. Short stature accompanied by spinal curvature and a barrel-shaped rib cage are also seen. So again, you can have poor formation of the lungs due to the barrel-shaped rib cage. Again, triangular facial bone structure and hearing loss. And then, however, with this type, the sclera of the eyes is usually normal. So as seen to the left, the sclera is completely white and there's no blue tint to it. So type 5 osteogenesis imperfecta. The phenotypes are similar to those with type 4. So again, short stature, barrel-shaped rib cage, normal sclera tint, poor muscle formation. However, there are large calluses that can be seen on x-rays where previous fractures have healed or where surgeries have occurred on the bones. Calcifications of the interosseous membranes between the radius and ulna are visible, and they tend to restrict movement. So in the images to the left, you can see the radius and the ulna, and there's kind of like this white coating in between those two bones where the interosseous membrane is, and that shows the calcification. Again, teeth and sclera are normal with this type. So type 6 osteogenesis imperfecta, again, also displaying phenotypes similar to type 4 OI. However, this is the most rare form. Type 7 osteogenesis imperfecta. This is one of the recessive forms of OI. It's caused by mutations in the CR-TAP and the LEPRE1 genes. It displays phenotypes similar to type 4, with very few cases resembling type 2. Shortened bones, especially the humerus and the femur, are also common here with this one. And we'll go over shortly the difference between recessive and dominant inheritance between all of these types. So type 8, the final type of osteogenesis imperfecta, also a recessive form caused by mutations on the LEPRE1 and the CR-TAP genes. Again, very rare. Displays phenotypes similar to those of type 2 and type 3. So in between the most severe and just one of the other types where you've got shortened bones, short stature as a whole, barrel rib cage, poor lung formation, blue sclera, poor muscle formation. Infants do have white sclera, so I guess that would relate more to the type 3. Round faces and small head structure. There's also a growth deficiency along with skeletal mineralization deficiency. So the patterns of inheritance with this disease. Types 1 through 4 follow an autosomal dominant pattern of inheritance. So autosomal and sex cells are affected, but only one mutant allele is required in the offspring to be affected by the disease. So they only need one dominant allele either from mom or from dad in order to have this disease. And again, that's types 1 through 4. Now, types 7 and 8 follow an autosomal recessive pattern of inheritance. So you're going to need a mutant allele from both parents in order to be affected by the recessive form of this disease. 85 to 90% of osteogenesis imperfecta cases are seen to be inherited via the dominant form of the mutation. That leaves the 10 to 15% left, which can be caused by the recessive form of the mutation. So the COL1A1 and COL1A2 genes are responsible for the dominant form of the mutation. We're going to go over that as well as the normal collagen structure. So let's just go over the normal collagen structure first. Collagen formation plays a vital role in the formation of the bones in the human body. Fibrillar collagens usually consist of long, continuous triple helical structures, and these structures organize themselves very highly. They're very, very organized into fibrils. The triple helical structure is composed of 2 alpha-1 chains and 1 alpha-2 chain. Mutations that alter the amount of type 1 collagen produced usually lead to mild forms of OI. So not that type 2 that we talked about earlier, all the other ones could be type 1 collagen mutation. Mutations that alter the structure of the alpha-1 chains and the alpha-2 chain lead to more severe phenotypes with higher lethality rates. So in regards to the COL1A1 and the COL1A2 genes, types 1 through 4 of osteogenesis imperfecta signify mutations within these two, and they control type 1 collagen formation. Now, the COL1A1 gene is located on chromosome 17 and is responsible for the alpha-1 chain's production. There are 2 alpha-1 chains. And then the COL1A2 gene is located on chromosome 7, and that's responsible for the 1 alpha-2 chain that is produced and needed. So this picture here, just kind of wanted to show the typical structure of a collagen fibril. We have the N and C terminal ends of that fibril. So the mutation itself, with the mutation being in the COL1A1 and COL1A2 genes, there are abnormal structure of collagen fibrils. This leads to the reduction in the amount of collagen produced. Methods for these mutations are due to glycine residue substitution, and this can take place within 3 different mechanisms. The dominant negative effect, which is also termed pro-collagen suicide. It involves pro-collagen molecules to contain both normal and abnormally structured pro-alpha-1 and pro-alpha-2 chains. So that's what we talked about on the previous slide. Abnormal chains prevent the folding of the protein into a triple helical conformation, leading to the degradation of the molecule. So it's not going to fold properly, and it's just going to fall apart, or it's not going to work properly. The second mechanism of glycine residue substitution is the interference of abnormal pro-alpha chains in the cleavage process of the N-propeptide from the chain, which produces irregular fibrils. The irregular fibrils display visible characteristics of being thick and short, with reduced total amount of collagen produced. So going back to this slide here, you'll see the N and C terminal ends, and the fibril being changed into being this thick and short molecule reduces the amount of collagen produced. So this third mechanism, interference with overall folding of the molecule, again, just having that glycine residue substitution affecting the whole folding of the molecule, which can then lead to death. A few smaller mutations which can occur that I didn't have listed on here involve the insertion or deletion of codons, which lead to premature termination or shifts in the reading frame. There's also the possibility of exon exclusion and intron inclusion on the mRNA. Again, all smaller possible mutations there. So the mutation occurring on the LAPRE1 and the CR-TAP genes, again, this is involving the recessive inheritance pattern of the disease. These 2 genes encode proteins forming the P3H1 CR-TAP Cyp B complex, which is responsible for the post-translational modifications to type 1 collagen. This form of inheritance is still undergoing extensive research, and there's not very much known about it. It's suspected to be able to lead to mutations that have lethal phenotypes, and mutation within the CR-TAP gene leads to moderate phenotypic display, while total loss of function is lethal. So it's okay if it doesn't function as normal, but it's got to function some in order to not create a lethal phenotype. So in regards to diagnosis, there's really minimal testing that can be done to confirm this disease, but up to 14 weeks into the pregnancy, it can be detected via prenatal ultrasound. The downfall of this is that the type of OI is hard to pinpoint in utero, just being that there are very few ways we can access the fetus while still in the mother. So chorionic villus sample, which is a sample of the placenta, can be performed up to 10 weeks into the pregnancy. And then after birth, if low bone density is present, DNA or biochemical testing is used to diagnose the disease in early childhood. In regards to treatment, most of the time this just relates to symptom management, managing the symptoms, the pain. Medications such as IV bisphosphonates and zoledronate can be used. And of course, physical and occupational therapy are almost a must. It's needed to go through this. And then joint replacement, fracture repair, and rodding procedures are also possibilities. And usually children and adults with this disease need mobility aids, such as walkers, canes, and crutches. So that is my reference slide for all the information in this presentation. And then right here, I was having issues earlier with getting the link to pop up while recording this video, but the link right here, the YouTube link, is about Malia, a 9-year-old girl with osteogenesis imperfecta. It's a really great video. Malia speaks about her disease and tells you the ins and outs of her daily function, what she can and can't do, what her history has been. It's a really, really great video, and I think that you'll really enjoy it. But thank you so much for listening to my presentation.